And today's session is going to be focusing on emerging treatments for dementia. This is a structure of our echo session, starting with our announcements and introductions, moving into our didactic, and then followed by our closing and our reminders. You are all muted upon entry, so if you would like to ask a question, you can go ahead and unmute yourself at any time. We also would love for you to ask your questions via the chat function, and we'll get them when we get to our question section. This is a CME accredited series, and our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management to expand access to geriatric specialty care throughout California and beyond. And our target audience is you all and anyone with an interest in the care of older adults. Today's session is accredited for 1 CME credit. If you attend, please go ahead and fill out the CME form that I will put in the chat, and it will be at the end of the series as well, where you can scan the QR code. This series is a part of the HRSA Geriatric Workforce Enhancement Grant at UCI, and one of our main goals for our grant is to train geriatric specialists, primary care providers, and health professions trainees, and help expand our geriatric workforce. And this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. As always, we'll go ahead and move on into our introductions. And if you can, we would really appreciate you putting in your name, your role, your site, and location in the chat. It actually helps us a lot with giving you your CME credits. So we'd love to see that in the chat. And while you do that, we'll go ahead and have our hub team introduce themselves. My name is Nika Seville, and I am the project manager for the GWEP program here at UCI, and I'm located in Orange, California here at UCI Health. And I'll have Dr. Sagal introduce herself.
Welcome, everybody. I'm Sonia Sagal. I am a clinical professor in the Department of Medicine and the Division of Geriatrics and Gerontology here at UCI. And it's my pleasure to welcome you all here today.
Thank you so much, Dr. Sagal. And Dr. Pereira.
Hi, everybody. I'm Manisha Pereira. I'm one of the geriatricians here in Orange at UC Irvine. Welcome.
Thank you so much. And PA Valerie George.
Hi, I'm Valerie George. I'm a physician assistant. I work here at the Senior Health Center in Orange, and welcome to everyone. Thank you.
Thank you so much. Looks like we have a lot of people introducing themselves in the chat. Thank you all so much for being here today. Today's presentation is on emerging treatments for dementia, and we have Dr. Stephen Tam here on the line. I will go ahead and let Dr. Tam share his slides. Give me 1 second, please.
Thanks, Nika.
No problem.
Am I able to?
You should be able to share.
So I'm on a different computer. It's going to be through the. Do you see it? You probably see the top of the browser, though, right?
I do. Yes, I see.
There's nothing I can really do about that, I think, unfortunately. So I'm sorry.
Okay.
Apologies for that.
No.
Okay. Hopefully this works. Okay, so thanks again, Nika. Thank you for having me. Today, we're going to talk about emerging treatments for dementia. I'm going to hone in specifically more related to the Alzheimer's treatments that are coming up for this in terms of the discussion, and even more specifically about the upcoming monoclonal antibody treatments that are directed at amyloid. So I think it's important for us to be familiar with this. As time progresses over the next year to 2 years to understand what this all details and involves. I'll introduce and give a little bit of a window to some of the other treatments and targets that are being developed. But I think just to kind of go over, the recent news and what's kind of in the works related to Alzheimer's is really the key that we want to focus in on. We'll go over a little case presentation. And so the case will kind of project it over time here, but this is somebody that I had as a patient, or I have as a patient, who was 77, and she came basically with short-term memory complaints, word finding, details, forgetting details, events, stuff on the calendar, having difficulty keeping calendars organized. Really noticed over the past year and a little bit more in terms of these kind of symptoms at the time. She did still do some work as a travel agent, was part-time, and she seemed to be managing okay. It didn't seem to be affecting her job performance, job function, her ability to, do her requirements as a travel agent. She denied any depression issues, sleep issues, occasionally off, but managed okay. She did have a history of arthritis, knee replacements, wasn't in too significant of pain, occasional Tylenol for that. No real significant alcohol history. The only other past medical history that of note was that she had high blood pressure and was on valsartan. Her yearly labs all tended to check out okay, no signs of diabetes, no hypothyroidism, anything of the sorts on there. She didn't have any focal findings on exam. And on her initial MMSE, she was 26 out of 30. She missed 3 on the recall. And 1 for not connecting the pentagon. So this was on her initial evaluation with me. We did end up having her do some more neuropsych testing. Her findings were more consistent with MCI or mild cognitive impairment. So once again, MCI or mild cognitive impairment is in excess of normal aging changes. It means that there is a detectable objective deficit that we can pick up. There's a subject to complaint, and then generally speaking, it's not affecting one's ability to do their activities of daily living, okay? So she met into this MCI range. It was amnestic in appearance. By all means, it would be for an Alzheimer's type pathology that was driving it in terms of how she fit in with this. 2 years later, during COVID, we had a video visit with her to follow up. At this point, she's had some progression of her symptoms, ongoing problems with the short-term memory complaints. Her basic activities of daily living were still okay, but her instrumental activities of daily living, she was needing more assistance with finances, more reminders with shopping. She got lost once while driving, ended up in another city locally here. Still no changes in mood or sleep or other new medical problems that would be contributing to it at this point. Her MMSE now at this point was 21 out of 30. So she progressed, she dropped about 5 points on there. Usually if somebody that has a neurodegenerative Alzheimer's type pathology, you kind of, if you're pretty confident that it's Alzheimer's and etiology, you do expect to see a drop a couple of points a year about on test scores such as the MMSE or the MoCA. Some of it depends on how much support that they have. They still missed 3 on the memory portion, and as well as a couple of points on orientation and the attention component in terms of Serial 7s at this point. She got additional follow-up neuropsych testing several months later and confirmed that she had shown progression from her initial evaluation. And this is more consistent with a mild dementia at this time, very amnestic appearing. We did have neuroimaging done on her. It was really non-revealing, no signs of stroke or mass on there or any patterns of asymmetry that was developing. So why are we presenting this case? I mean, we're showing basically the progression of MCI to Alzheimer's over the course of time. I think that that's the key with this as it relates to some of these emerging treatments, because now we're in this window where I have a patient like this, and there's a lot of debate about some of these emerging treatments and whether or not they help with somebody. And I wanted to bring a case like this, is that while we wait for these emerging treatments to come on, and figure out the finances associated with it, the science behind it, I'm kind of left with, hey, these patients, and here I'm left with a quandary because I might have a potential treatment for this person, but I'm kind of stuck because I can't really, 1, at this point, get them the treatment, and 2, if I wait too long, she might progress to a little bit farther, and she may not be indicated for the treatment when you review some of the data surrounding this. So I just bring it out here because it's something I think important to think about with our current existing population of patients, of people with dementia, because they're kind of caught in this in-between phase, and what to do with it, I think, represents its own challenge. I don't have the answer for it per se, but I wanted to point it out there so that we are aware of it, okay? So again, epidemiology and impact, significant cause for disability in terms of Alzheimer's dementia. Estimates are high in the number of folks that have dementia due to Alzheimer's in the United States, in the high 5 or 6 million range, with it expected to increase to about 14 million by 2050 to 2060 at that time. We know the incidence continues to increase with age, significant cause of disability, institutionalization, cost of care, lost productivity. The estimated cost financially due to the care surrounding that person, lost wages, all of it is estimated to be upwards of $200 billion annually when you think about it in terms of the numbers here. So pretty significant impact, and stresses the need for some kind of treatment for this in terms of figuring out where we're going to go in treating dementia, specifically Alzheimer's, but the other kinds too as well. So significant impact on the caregivers and the family members for those that are suffering from dementia and Alzheimer's. So a significant amount of stress surrounding it as well. So all things for us to keep in mind, with like that patient I just painted for you here. So current treatment options, since 1996, that's when Aricept was really first introduced. At the time, it's really been those two, right? There hasn't been anything new introduced to the market until 2020. Literally, between these two medications here in terms of what's actually FDA approved. Aricept, donepezil, and the cholinesterase inhibitors, the other ones are galantamine, rivastigmine. They're all cholinesterase inhibitors. There's a small, modest improvement in cognition and ADLs in terms of what the studies show. On what it translates to in terms of the test scores, it's been about 1.37 points on an MMSE, so 1 to 2 points on an MMSE in terms of what the early benefit of it is. Nobody really knows how long to keep that medication on board, okay? Just to give you a perspective. There's a test called the ADAS-Cog, which is a 70-point measure used in the original studies, and it seemed to improve folks by about almost 3 points on that test. But it's almost like an MMSE scaled out more with more questions surrounding it. If you put it in that kind of perspective about global functioning on there. So just to give you a sense, it's not much of an improvement. It was there, and we don't really know how long this to continue after. Memantine, approved in 2003. Its mechanism is a little bit different, and it's been approved for moderate to severe AD. We see different combinations of memantine used with Aricept, but once again, the improvement on a score on a test tool like the MMSE is about 1 to 2 points on that particular tool like an MMSE. So again, something to keep in mind in terms of what you're going to get in terms of benefit from the current treatments. Many other treatments options have been looked at, antioxidants, hormonal therapy, different vitamins, different dietary supplements, ginkgo biloba. A lot of research is still being done in these areas here. A lot still being done in terms of trying to understand. A lot have been disproven, or you continue to need more information about timing, dosing, about when to give these different things. So those are some of the things that are being looked at, or have been looked at and are still kind of being reviewed. But nothing is really proven to come forth that is guaranteed to fix the whole situation on there, right? And so that's when it goes into the current emerging treatments that we have online as of now. So the main thing that's surrounding this, the news is really the news of aducanumab and lecanemab over the last 2 to 3 years, essentially. And it focuses in on the concept that for Alzheimer's disease, the main characteristic finding is really the presence of beta amyloid and plaques in the brain. They seem to cause different variations of toxicity, neuronal toxicity, in the various forms. It comes in fibril form, it comes in plaque form, there's oligomer forms. So, there's a certain whole biochemistry surrounding the beta amyloid. The hypothesis has been that this is kind of like the main contributing factor to the clinical decline. But, whether or not that's fully proven, those are the things that are still we need information on, continuingly with this. Questions also surround, or other parts of the hypotheses also surround tau as another target for this, as well as other mechanisms that regulate these different molecules, okay? So a lot of the research and science behind this is kind of centered in these areas predominantly here, all right? So the main thing, and we've seen different things like vaccines to beta amyloid, just other kind of areas that have been developed over the years. But the most promising thing really has been the presence or the development of the monoclonal antibodies against beta amyloid. Once I said prior to 2021, other drugs had really failed any kind of phase 3 clinical trials. And there's really aducanumab that had kind of the most groundbreaking news in 2021 about this. And so, interestingly enough, they actually, the aducanumab is a monoclonal antibody. It actually went through a futility analysis, and it actually originally was pulled, but further analyses did show some benefit that kind of resulted in its accelerated approval pathway on there, right? And so that's kind of where we are now with it. We'll dive a little bit deeper into this, and I apologize in advance if this sounds a little bit like Journal Club, but I think it is important to understand, why these are, why it has gone through the process that it has been. Okay, so aducanumab was the first of the monoclonal antibodies to get this recognition. Lecanemab followed with an accelerated approval. That's another monoclonal antibody. And then it followed with a full approval process just recently, 2 months ago, or in the last couple of months. Nika, I'm sorry, are you guys picking up a lot of background noise from me? There's an air conditioning in the back unit that's, I don't know if it's gonna.
No, I don't think so.
Okay, so you can hear me clearly, right?
Yes, correct.
Okay, we'll keep on proceeding. But so lecanemab was the kind of most recent with a full approval process through the FDA in the last couple of months. And then donanemab is the third of these antibodies that originally did not get accelerated approval, but it did have some encouraging news earlier in the year, and they do plan on applying for FDA approval based on the results that they're generating from it. So there is some hope about this. And we'll look at what that means actually, and whether or not that actually translates into clinical results versus what it's actually doing here. So I think that's an important concept to grasp, okay? So aducanumab, again, is the first of those three antibodies to generate some excitement and news. It is a monoclonal antibody that targets aggregative forms of beta amyloid, okay? There's still uncertainty whether or not patients with Alzheimer's disease actually benefit clinically from aducanumab. What we do know is that we can see that amyloid is removed from the brain based on PET scan results, okay? So we do see beta amyloid from doing the PET scan or CSF seem to be cleared or removed. However, the clinical benefit is kind of like, where the sticking point of all this really is, okay? So aducanumab is indicated right now for mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease. That information is based on the presence of amyloid being on PET scan or lumbar puncture or not, okay? So there is an important requirement for that. Aducanumab, like the trials, really follows monthly infusions, which would be typically at an infusion center. So keep that in mind in terms of where you're thinking about how to administer this or the protocols that are going to be required, the costs that are associated with it, okay? And you're going to require a PET scan or a lumbar puncture to get patients at this point enrolled on a protocol to receive it at this point, okay? So it's something to keep in mind. Those folks that have non-Alzheimer's type pathologies should not be getting aducanumab, and that's probably true for the lecanemab and donanemab and these other monoclonal antibodies at this point. I don't know what kind of room there's going to be in the future for folks that have a mixed etiology for their cause of dementia. So whether or not they have a vascular dementia or Lewy body dementia mixed with Alzheimer's pathology, those are all questions I think that still come to mind on here. And there is a concern about microhemorrhage development and transformation into a macrohemorrhage or major bleeding in the brain that we saw with studies. And so that is another potential side effect to consider when thinking about aducanumab and these treatments. Okay, we'll go into that a little bit more here. So this is just an example of what a PET scan with amyloid imaging might look like. But when you scan the brain, you're using a radioactive tracer to amyloid, amyvid. There's some others that are floating around out there. And then you're taking a PET scan picture of it and then reading and detecting the levels of amyloid that are present on there. Okay. Just, so along with the whole macrohemorrhage concerns on there, or microhemorrhage concerns, the other risk factors to consider is whether or not when a patient's on anticoagulants, they have AFib or they have antiplatelet use because they have a significant heart history, other bleeding disorders or conditions that would carry a risk for bleeding in the brain. If they have other unstable medical conditions, one thing to note too is that this whole condition of microhemorrhage, I'll dive into what that is a little bit more, but the ApoE gene, the ApoE4 allele of the ApoE gene seems to carry a higher risk for that microhemorrhaging and edema associated with it. And so, whether or not we start to identify folks that do have an E4 allele, which carries some of the higher risk for Alzheimer's disease as well, remains to be in question. Is this a standard test that we're going to check on folks as we administer this? So all kind of questions that are left unanswered if that's the case. Surrounding aducanumab, as where we stand now, there's still some uncertainty over the cost and the payment for. There are other questions about guidance regarding how long we treat it for. Do we stop if a follow-up PET scan on a clinical patient shows no further signs of amyloid present? I don't know that we have all these questions answered quite yet at this point related to this and possibly the other antibodies. So all science and information and evidence that I think we're still gathering at this point. The microhemorrhage and the associated swelling with it is what we falls into this group of amyloid-related imaging abnormalities, so what we call ARIA. And in the case of aducanumab, so Aduhelm is the other name for it, we saw that in the highest dosages of the aducanumab, about 40% of the patients showed signs of ARIAs present. Again, the risk was greater when you have the E4 allele of the ApoE gene on there. And usually the abnormalities seem to show up more commonly in the first several doses or when the dosage was escalated in aducanumab. So the ARIAs are broken down into two main categories. One is ARIA H, standing for hemorrhage. These were signs of a microhemorrhage. So even though present in about 40%, conversion over to a macrohemorrhage, so full-on bleeding in the brain, was still fairly infrequent, but enough of a concern. The presence of a microhemorrhage usually often occurred with the presence of some edema. And usually what happened in the clinical studies is that we look for stability of these before proceeding. There was different kind of conditions in the protocol as we manage this during the trials here, okay? ARIA E is the same kind of amyloid-related imaging abnormality, but with the presence of edema present. And most patients with this were asymptomatic, 70% were. Others did have fatigue, headache, confusion, dizziness. These are other kind of potential symptoms that are related to ARIAs present here. These ARIAs were graded as mild, moderate, or severe. There's actually a rating scale for this. And for the edema component, of almost 90% actually resolved over time. So, usually from a trial standpoint, in terms of how we're following these protocols, we're looking for stability of those microhemorrhages, meaning that they're not getting bigger and turning into macrohemorrhages before proceeding, and for improvement in the edema, usually being the case. Or whether or not they were symptomatic and the symptoms resolved from that process. This is just a couple of pictures of One on the bottom corner is what a microhemorrhage might look like. One thing is that when we're getting MRIs to follow folks as they go through this treatment, you want to be, your MRI centers and the radiologists, they want to be skilled at reading these microhemorrhages on there. So usually, like in a clinical trial, they had, for these MRIs, they would get a local reading at the place where it was done, and it was also sent to a central site who was an expert on these for further counts and evaluation. Sometimes you see little discrepancies between the two in terms of what the count is. Local reads generally tell you that, okay, there are some microhemorrhage findings present. The central count would be the ones that actually count the number of microhemorrhages for us in the clinical trials related to this here. And so the table up on the upper left corner here gives you an idea of what mild, moderate, and severe ratings would look like in terms of the number of microhemorrhages present, the presence or not of edema, and so that would be a way for the readers to quantify this here. Whether or not this kind of scale or system gets implemented in the radiology centers as we roll out these antibody treatments in the future, I think that those are all parts of the discussion in terms of what to do in terms of this following and monitoring process, okay? Usually with the ARIAs, I alluded to earlier, for those folks that have just a mild ARIA and they're asymptomatic, they might be able to continue along with close monitoring and monthly MRIs, which is what was done in many of the trials on there. And it shouldn't be the dosages, depending on where you're at. With aducanumab, there is a dose escalation phase on there. The dosages should not be escalated until the edema is improved in this kind of scenario. So if you give aducanumab now or are able to, there's still an escalation dosage up on it. So this is something to keep in mind. Again, all things I think more or less for us to think about as we develop these protocols and figure out what is going to work on there or not. For symptomatic patients or that they have moderate to severe findings, again, headache, dizziness, any of those things that might be associated with it, usually, the aducanumab is held and maybe restarted if there's documented stability of the microhemorrhages and that the edema is resolved and that their symptoms are improved at that point. What's left to remain to be known is whether or not you keep it at a lower level, a lower dosage of the aducanumab, despite having some of these findings or adverse effects potentially on there. I don't think we know the answer and the benefit of that. The benefit that they showed was at a higher dosage of the aducanumab in terms of seeing the benefits. So that gets into discussion. Okay, how beneficial actually aducanumab is. Okay, so from all the studies that we have regarding aducanumab, there is a pretty consistent showing of reduction in the level of amyloid in the brain on PET scans and lumbar punctures in different studies. Okay, what gets into inconsistencies or where the concern was and why there are some controversies surrounding this initially was just whether or not there's a clinical benefit, really. Okay, there were more or less two main trials that were run kind of simultaneously related to this on participants that had MCI and mild dementia. And once again, both of those trials did show decreased levels on brain amyloid based off of a PET scan. Okay. Originally, the analysis, there was a futility analysis done, did not show association between reduction in amyloid and clinical outcomes. Later on, while they were, in the process of all this and patients were gathering while all the data was gathered up, later it was found that on one of the primary outcomes, the CDR sum of boxes, that there was actually a small clinical decline decrease in the rate of decline compared to baseline for this measure called the CDR sum of boxes on there. Okay, in one of these two trials, so the eMERGE and ENGAGE. On the eMERGE, it showed a small clinical decline on there. The absolute difference is, unclear statistical significance on there. It was 0.39. But the relative difference showed that different. The relative difference in the CDR was important and significant enough. And then there were smaller but statistically significant benefits in other areas of the MMSE, the ADAS-Cog, and another measure on there. So this is what a CDR looks like, and you can generate a global score off of this, as well as a sum of boxes. And there's just two ways to calculate what this is. You have a rater that is basically measuring the patient on these different items on here. And this is, essentially what we are tracking from this and many studies that are using a primary outcome, okay? They're looking at the different areas of a participant and making a judgment in terms of the level of impairment that's there, okay? So this is what went into it. Secondary outcomes usually are things like a research level, MMSE, some of the other things that were mentioned, the ADAS-Cog and whatnot. And the CDR, clinical dementia rating scale, usually folks will start off at one of these levels and you're looking for, increases in score to see their progression through the different stages on here. And so once again, the absolute difference on the emerge scale was about a 0.39 in terms of that number, in terms of, the rate of progression of these numbers here. So that's something important to keep in mind in terms of the scale of what they actually saw in terms of clinical significance on there. I think this is very informative, I think, from the standpoint of that, just removing all the plaque, the impairment, the amount of impairment, from this kind of rating scale, it wasn't all that, grand in terms of what you expected on here. At the same time, too, you can look at other things, the impact of the neuronal damage, that's already done, and, other pathways on here. So there are efforts, in terms of this research to pair up antibodies with other molecules to see if it might need some kind of combined therapy or treatment, okay? So again, things to keep in mind in terms of what was being measured on these research studies, okay? And so the other trial that was going on at the same time along with emerge, called engage, again about 1,600 to 1,700 participants, show no difference in the CDR sum of boxes in this too. So that led to some controversy of whether or not they met their primary goal or endpoint of having both trials meet those endpoints, whereas only one of the two did, right? In terms of looking at the results of this. Okay, so that's another thing to keep in mind. The adverse effects, including ARIA, was about 40% in the patients treated with the highest doses in terms of ApoE4. So that's something to keep in mind. This is currently undergoing phase 4, a confirmatory trial. The cost initially of this antibody was expected to be about $56,000 a year, later lowered to $28,000. Medicare projected costs surrounding this. If you follow trial protocols and do the MRIs and the PET scans, it's probably about $7 billion annually to be able to do this. It's going to be more if folks do use off-label and whatnot. And thus far, Medicare had it said that, yeah, you can do this if it's linked to a trial going on at the time. So those are, I think, the important pieces of information surrounding this here. If I think folks are still trying to figure out what the protocols surround this aducanumab as well as lecanemab, the second antibody that we will talk about. So lecanemab is the second antibody. It binds to beta amyloid protofibrils, so it's a little bit different in terms of where the antibodies target to. Initial phase 2 trials didn't meet the primary endpoint on one of the measures called the ADCOM. This is another clinical rating measure tool on there. But it did show decrease amyloid on PET scan and did show decreased rate of decline on other measures, that CDR sum of boxes and the ADAS-Cog on there. So they went on to proceed and do a phase 3 study, and that did show a decrease in the primary endpoint of the CDR sum of boxes at 18 months compared to placebo in almost 1,800 participants. The absolute difference is what I have underlined here in that CDR sum of boxes, using a least squares mean. was about minus 0.45 on there. And so, you know, I think, again, you have to look at what the scale of that is. And you know, I think that's where some of the continuing questions still arise. What does that actually translate to in terms of the clinical benefit? But nevertheless, on this primary measure and primary endpoint, there was a decrease in that amount of progression. Okay. The findings related to ARIA were less in this antibody compared to the aducanumab on there for this particular study. This is not a head-to-head study. That's something to keep in mind. And so ARIA-H was about 17.3%, in which 0.7% were symptomatic from. And then ARIA-E was about 12.6% in terms of being present. So beginning of the year, they actually got accelerated approval granted. And they actually got full approval in July of 2023. So 2 months ago, essentially at this point. Cost is somewhere about the same range, 26,000, but also need to factor in the MRI, the PET scan costs, and whatnot. I didn't mention in terms of aducanumab, but there is a titration up in terms of the dosing on there. And there are multiple MRIs during that process to follow an individual and monitor for ARIA presence on this. As far as what lecanemab looks like right now, it's you know, a 10 milligram per kilogram dosing. It's bi-weekly in terms of an IV infusion. And you know, I don't know yet what the monitoring protocols are going to look like. I think, you know, folks are trying to work out, you know, what it is at their individual institutions and whatnot. And there's an ongoing open label extension. And then there's been 3 deaths due to macrohemorrhage present. 2 of them did happen to be on blood thinners. 1 happened to have amyloid angiopathy pre-existing. So those are other conditions that, again, we'll want to screen for and be aware of when we factor this in. Okay. So lecanemab, if you go by this number in terms of what we saw with side effects related to ARIA and bleeding, they do appear to be a little bit less from that perspective. Donanemab, yeah, I have a hard time keeping all the antibody names straight, but donanemab is the 3rd antibody that had exciting news earlier in the year. It targets A beta plaques, the pyroglutamate form of beta amyloid. And there was essentially a phase 2 and a phase 3 study done. The phase 3 study done, again, looked about 1,700 participants, and they met their primary endpoint of another clinical measure called the IADRS. And so the CDRSB, the clinical dementia rating scale, some of the boxes also appear to show less of a decline than placebo. More information is probably coming in this, you know, that we'll find later on. And like I mentioned earlier, based off of their phase 2 study, which an application for accelerated approval was sent in, they didn't get that. It looks like they'll probably be requesting for full approval at some point soon too. Okay. Other antibodies have been looked at, directed at different parts of beta amyloid. And there have been other things that are subcutaneous inversion in terms of administration versus IV. 2 of them, at least, the top one here was discontinued and a new version is being developed. Solanezumab was discontinued. They were on an open label extension earlier in the year, but ultimately did not show a benefit in amyloid reduction or clinical measures. And so that was discontinued. And then there's an additional antibody that's being looked at that looks like they'll probably have results next year. So that's kind of the landscape of where the antibody literature is right now and what we would expect to have discussions on in the future and what might potentially be there. So, you know, just to prepare ourselves. Other targets that are being looked at include these that I have listed here with results over the next 4 years or so in terms of being expected. You know, there are studies looking at targeting tau, the tau tangles, which is the other kind of main pathological finding on here with the results later. You know, some of this is being also comboed up with the lecanemab, the other antibodies too. So that's the other way folks are targeting this. Terdemontide is it was actually developed as an anti-cancer drug, but may have protective effects against beta oligomers on stem cells. So some studies have been looking at this in terms of whether or not there's a benefit for Alzheimer's dementia. Semaglutide, other name is Ozempic or Rybelsus for diabetes. There actually did seem to be an improvement in learning and memory of rodents that have the genes, transgenic mice that have Alzheimer's on there. And so this is also being studied, as well as other smaller molecules that don't act as antibodies, but target different forms of beta amyloid, including the vermostat on there as an option. So just, other areas are being developed in addition to the antibodies. But I think we're still probably about 3-4 years out from all the data being collected for it. Things to keep in mind. So that pretty much covers kind of like what some of the landscape is out there right now in terms of Alzheimer's therapy. But we always try for any of our non-pharmacological measures. There is still research going on in terms of what other methods that we can use, cognitive exercises, cognitive rehab, exercise, these other areas and what impacts they might have in terms of on an individual that has Alzheimer's dementia and the symptoms that they have. So, most of these are probably, not too high in terms of risk of side effects, microhemorrhage bleeding on there, and they probably impact other areas of an individual's health. And so we always tend to try to stress these things anyways in terms of addressing some of the cognitive and the behavioral symptoms that come up in individuals that have dementia. So important to keep in mind. One thing that we do in terms of the Dementia Care Aware program is, we always try to strive to implement a brain health program when we do make a diagnosis of dementia in an individual. So trying to set that up is always something that we always try to encourage folks on there. Going back to our case, originally why I rose it up, well, they are asking me. So initially, this person was diagnosed with MCI. Later on, 2 years, showed some progression. We made a diagnosis of mild dementia, likely due to Alzheimer's on here. Got started on Aricept in this scenario. This is an individual that's asking about some of these newer therapies in terms of like monoclonal antibodies. And at this point, they're interested. They seem like good candidates, but at the same time, too, I don't know that we have that available to them right now because we just don't have the protocols in place. We're still kind of waiting on some of the financial decisions surrounding lecanemab. We're still waiting on information on donanemab, which does all in all intents and purposes might even have a more defined period in terms of when we know about like how long to use it for with clearing of the amyloid or reduction in amyloid. So those are all some of the questions that are still kind of surrounding this. But in the meantime, I can't, I don't really have a protocol in place to get this person. She doesn't have $28,000 a year lying around for this at the same time too. So I'm just illustrating some of the questions that I'm trying to balance out with them, while we are waiting at this point.